What if I told you that the surgery your doctor just recommended could be the single most dangerous decision of your life after the age of 60? Not the disease, the surgery itself. Look, I have watched patients walk into hospitals with mild back pain and leave in wheelchairs. I've watched men and women survive complex operations only to lose 6 months, a year, sometimes their entire personality to a complication nobody warned them about. And here is the part that should stop every single person watching this video cold. The older your body gets, the harder it has to fight just to survive the operation. Not the illness, the operation. And if you are over 60, or you love someone who is, what I'm about to share in the next 25 minutes could genuinely change the course of your life or theirs. Hi, before we go 1 inch further, I want you to know something about how I make these videos. Because trust matters more than anything in health. I do not sit down and record opinions out of thin air. Every single video I produce is built on hours of careful research, peer-reviewed studies, clinical data, conversations with leading specialists, and decades of medical understanding. I don't chase trends. I don't repeat what's popular. I give you 100% of my honest opinion, even when it goes against what the mainstream tells you. Because my goal is simple. I want you to walk away educated. I want you to walk away empowered. And I want you to live a longer, sharper, healthier life because of the information I put into your hands. That is the only reason this channel exists. So if you're new here, welcome. Stay close, because today's topic is one of the most important conversations a person over 60 can ever have. Now, let me ask you something. If you took a brand new car and a car with 200,000 miles on it, and you put them both through the exact same stress test, would you expect the same result? Of course not. Nobody would. And yet for decades, medicine treated a 70-year-old body the same way it treated a 40-year-old one. Same surgical protocols, same recovery expectations, same anesthesia doses, same timelines. That is finally starting to change, but not nearly fast enough. And the patients paying the price for that lag are sitting in waiting rooms across America right now. Here's what actually happens inside an older body the moment it goes under general anesthesia. The heart has to work harder because circulating blood through a body in shutdown mode is metabolically expensive. The lungs take significantly longer to clear the anesthetic agents. The kidneys, already running at maybe 60 to 70% of their youthful capacity, slow down even more, struggling to filter the cocktail of medications pumping through the bloodstream. And then there is the brain. This is the one that surprises people the most. The brain becomes temporarily disoriented in ways that can last weeks, months, and sometimes never fully resolve. Doctors have a name for this. It's called post-operative cognitive dysfunction, POCD. And in patients over 70, research from Johns Hopkins and Harvard Medical School has shown it occurs in up to 40% of major surgery cases. 40%. Why? Because anesthetic drugs cross the blood-brain barrier and trigger inflammation in the very synapses that store memory and language. In a younger brain, microglial cells, the brain's cleanup crew, sweep that inflammation away within days. In an older brain, those microglial cells are slower, fewer, and overwhelmed. The inflammation lingers, and the patient comes home different. Now, I want to be absolutely clear about something before we go any further. Age alone is not a reason to avoid surgery. I have seen 80-year-olds bounce back from major operations faster than some 50-year-olds. Age is just a number. But frailty is not just a number. Frailty is a measurable medical condition. It means the body's biological reserve has dropped below a critical threshold. According to data from the Mayo Clinic, roughly 40% of adults over 75 show clinical signs of frailty. That number jumps to nearly 60% over the age of 85. So here is the real question, and write this one down. It is not whether someone can survive the operation. It's whether they can survive the recovery. Those are two very different things. And that distinction is the entire foundation of everything I'm about to share with you. Let's start with surgery number one, open heart surgery in frail patients. Coronary artery bypass grafting, what we call CABG in the medical world, is one of the most common major operations performed on older Americans. The concept is beautiful in its simplicity. Your arteries are blocked. We reroute the blood flow using vessels harvested from your leg or chest. And for the right patient, it works. It saves lives. But here is what the consent form glosses over. Open heart surgery requires stopping your heart completely. Yes, completely. We put you on a cardiopulmonary bypass machine, a device that performs the work of your heart and lungs while we operate on you. For a 60-year-old in good shape, that is manageable. For a 78-year-old with mild kidney disease, controlled diabetes, and early cognitive decline, that bypass machine is a full-scale assault on every single organ in the body simultaneously. Studies published by researchers at the Cleveland Clinic show that in frail elderly patients, traditional open heart surgery carries a 30 to 40% risk of major complications: stroke, kidney failure, prolonged delirium, extended ventilator dependence. And here is the number that should genuinely stop you cold. Up to 15% of high-risk elderly patients do not survive the first 30 days after this surgery. So, what's the alternative? In many cases today, there is one. It is called TAVR, transcatheter aortic valve replacement. And there are similar catheter-based options for blocked arteries that never require stopping the heart or cracking open the chest. Less dramatic than surgery, but far kinder to a body that needs kindness, not a battle. Does this mean you should refuse heart surgery? Absolutely not. It means you should ask your cardiac surgeon one question: am I a candidate for a less invasive approach? That single question could change everything. Surgery number two, aggressive spinal surgery. Back pain after age 60 is almost universal. I don't know a single senior I've spoken with who hasn't mentioned their back at some point. And the solution that is being offered more and more aggressively is spinal surgery, fusions, multi-level decompressions, hardware screwed up and down the spine like scaffolding. Now, I need you to hear this clearly. Some spinal surgeries are absolutely necessary. A spinal cord being actively compressed, causing loss of bladder control or sudden paralysis. That requires surgical intervention immediately, no question. But elective spinal fusion for chronic back pain in an elderly patient? The evidence is genuinely troubling. A landmark study referenced by spine specialists at Stanford found that in patients over 65, complex spinal fusion carried a complication rate exceeding 40%. And the most common complications were not minor inconveniences. We're talking about blood clots, deep wound infections, hardware failure, and something called adjacent segment disease, where the vertebrae directly above and below the fusion start breaking down, because the natural mechanics of the spine have been permanently rewritten. Why does this happen? Let me explain it at the cellular level, because this is the part doctors rarely take time to discuss. Your spine is not a stack of bones. It is a living, breathing column of intervertebral discs, ligaments, nerves, and tiny shock absorbers called facet joints. Every single time you walk, twist, or bend, that load is distributed across dozens of segments working in harmony. When you fuse two vertebrae together with titanium hardware, that natural load distribution doesn't just disappear. It gets redirected to the segments above and below. Those segments now absorb forces they were never designed to handle. The discs degenerate faster. The facet joints inflame. And within 3 to 5 years, the patient is often back in the surgeon's office with new pain in a new location. And here's what frustrates me the most: the pain relief itself. Studies from Harvard-affiliated hospitals show that for many elderly patients with degenerative spine disease, aggressive surgery provides no better long-term pain relief than a structured program of physical therapy, targeted injections, and core strengthening. No better, but with dramatically higher risk. I once heard a brilliant spine surgeon say, "Sometimes the best operation is the one you don't do." I think about that line a lot. So here's my question for you. Have you ever been told that surgery was your only option for back pain? Drop the word yes or no in the comments. I genuinely want to know how widespread this has become. Your answer might help someone else watching make a better decision. Surgery number 3, major cancer resections. This one is the hardest to talk about, because the moment a patient hears the word cancer, the instinct is immediate, primal, and powerful. Cut it out, remove it, get rid of it, now. And I understand that completely. But here is what 2 decades of clinical evidence has taught the surgical community. The goal of treatment is not just to remove the tumor. The goal is to give the patient more good years of life. And sometimes, not always, but sometimes, major surgery in a frail elderly patient does the exact opposite. Let me give you a real example. Pancreatic cancer surgery, the Whipple procedure, is one of the most complex operations in all of medicine. We remove the head of the pancreas, part of the small intestine, the gallbladder, and part of the bile duct. The surgery itself takes 6 to 10 hours. In younger, healthier patients, it can extend life dramatically. In an 80-year-old with heart disease and reduced kidney function, the surgery may technically succeed, the tumor is gone, and the patient still passes away within weeks from surgical complications. Not from the cancer, from the operation. Surgeons have a term for this. It's called futile surgery. And research published through the American College of Surgeons found that nearly 1 in 5 elderly cancer patients who undergo major resection experience something called failure to rescue, meaning a complication occurred that the weakened bodies simply could not survive. So what is the conversation actually worth having? Ask your oncologist this, and ask it directly. If we don't operate, what does watchful waiting, radiation, immunotherapy, or targeted therapy look like for someone of my age and my health status? That single question opens a door that millions of patients never even knew existed. And sometimes the answer behind that door is genuinely better. Cancer treatment in 2024 is not the cancer treatment of 2004. Targeted therapies, immune checkpoint inhibitors, and precision radiation can, in select cases, extend life as effectively as surgery without the trauma of an operating room. Surgery number 4, elective joint replacement in severely ill patients. Hip and knee replacements are among the greatest medical innovations of the last century. I will say that without reservation. For the right patient, a new hip transforms quality of life. People go from struggling to walk to the mailbox to playing tag with their grandchildren. It is genuinely remarkable. But here is where it gets complicated for older adults. The word elective means the surgery is planned, not emergency. You have time to think, time to prepare, and crucially, time to ask whether this is the right moment for your specific body. Because here is what the data from major research hospitals consistently shows. In patients over 75 with 3 or more serious health conditions, heart disease, diabetes, chronic kidney disease, obesity, elective joint replacement carries significantly elevated risk of perioperative complications. Blood clots are the biggest danger. Deep vein thrombosis, clots forming silently in the legs, can travel to the lungs and become life-threatening pulmonary embolisms. In elderly patients with reduced circulation, that risk is substantially higher. Add post-operative pneumonia from prolonged immobility. Add hospital-acquired infections from compromised immune function. And the picture becomes much more complex than the smiling brochure suggests. Now, here's what I really want you to take away from this section. The question is not, should I ever have a joint replacement? The question is my body in the best possible condition right now? Optimizing blood pressure, blood sugar, body weight, and cardiovascular fitness before elective surgery can reduce complication rates dramatically. Some leading hospitals, including programs modeled on Mayo Clinic standards, now require formal prehabilitation. 6 to 12 weeks of supervised exercise, nutritional optimization, and medical tuning before they will even schedule a joint replacement for a high-risk elderly patient. That is exactly the right approach. Has your doctor ever even said the word prehabilitation to you? Most people have never heard it, and every single one of them deserves to. Surgery number 5, emergency abdominal surgery. Now, I need to pause here because this one is different from the others. You don't choose emergency surgery. It chooses you. A perforated bowel, a ruptured appendix, sudden internal bleeding. These situations don't wait for a calm conversation in a doctor's office. But here is why this surgery still belongs on this list. Knowing the risks before the emergency happens changes how families make decisions in those terrifying midnight moments. Emergency abdominal surgery in patients over 75 carries some of the highest mortality rates in all of surgery. We're talking 30 to 50% in the most severe cases. Not because surgeons are unskilled, but because an elderly body under sudden trauma is fighting on too many fronts at once. The liver, kidneys, heart, and lungs all get hit simultaneously. And the inflammatory response that a younger body controls within days can spiral in an older body into something called systemic inflammatory response syndrome, SIRS, where multiple organs begin shutting down in sequence. It is exactly as serious as it sounds. So what can you actually do with this information? 2 things. First, do not ignore abdominal symptoms. Persistent pain, unusual bloating, sudden changes in bowel habits in someone over 60 deserve prompt medical attention. Catching problems early means treating them before they become emergencies. That one habit alone can change everything. Second, Have the conversation with your family now. Not in the hospital corridor at midnight. Not while a surgeon is asking you to sign a consent form. Now. What are your wishes if emergency surgery becomes the only option? What quality of life truly matters to you? These conversations are not morbid. They are one of the most loving things you can possibly do for the people who will be standing in that corridor someday. All right, we've covered all 5 surgeries. Now let's talk about what you actually do with this knowledge. Because information without action is just anxiety. And anxiety is the last thing I want for you. Before any major surgery, planned or recommended, there are 4 questions every patient over 60 should ask. Grab a pen, write these down. Question 1, what happens if I do not have this surgery? A good surgeon will give you an honest answer. If the answer is nothing urgent changes in the next 6 to 12 months, you have time. Time to think. Time for a second opinion. Time to optimize your health. Question 2, is there a less invasive alternative? Medicine has changed enormously. Robotic surgery, endoscopic procedures, catheter-based interventions. Options that didn't exist a decade ago are now standard at most major American hospitals. Question 3, what does recovery realistically look like for someone with my age and my health profile? Not the average patient, you. Your heart, your kidneys, your medications, your living situation. The answer should be specific, not generic. And question 4, and this is the one almost no patient ever asks, what is your personal complication rate for this procedure in patients over 70? Surgeons track this. They know their numbers. A confident, honest surgeon will tell you. If they seem uncomfortable with that question, that itself is information worth having. Before I close out, I want to leave you with something genuinely hopeful. Because this is not a video about fear. This is a video about options. And those options have never been more powerful than they are right now.
Minimally invasive surgery has transformed what's possible for elderly patients. Laparoscopic procedures with tiny incisions and camera guidance dramatically reduce recovery time. Robotic-assisted surgery now allows precision that human hands alone simply cannot achieve.
Catheter-based cardiac interventions have opened doors for patients who would never have survived traditional surgery. And beyond surgery itself, optimized medical management is genuinely powerful. The right combination of medications, supervised physical therapy, targeted injections, and nutritional support can manage many conditions that previously seemed to demand a knife. The body wants to heal. Sometimes our job as physicians is simply to get out of its way and give it the tools it needs. I want to tell you about a patient I worked with. I'll call him Gerald. 71 years old, retired engineer, sharp as a tack. 3 different surgeons had recommended open heart surgery for a blocked coronary artery. 3 surgeons, 3 recommendations. Same answer every time. Gerald wasn't afraid of surgery. He was afraid of losing himself. He had watched his wife go through a major operation 2 years earlier and come out confused, exhausted, and never quite the same person. He told me, she went in as my wife and came out as someone I had to take care of. That sentence has stayed with me ever since. When I sat down and reviewed Gerald's full profile, kidney function, frailty score, cognitive baseline, I spent 40 minutes with him, not 15, 40. And I told him the truth. Surgery was an option, but so was an aggressive medication protocol combined with structured cardiac rehabilitation. The data for his specific profile showed comparable 5-year outcomes between the 2 approaches. He chose the non-surgical path. That was 4 years ago. Last month, he sent me a photograph. He was standing at the top of a hiking trail in Colorado with his 2 granddaughters, both taller than him now, grinning like he had won the lottery. Here is what I need you to truly understand. This is the single most important sentence I will say today. A surgical recommendation is not a verdict. It is the beginning of a conversation. You are not a passive recipient of medical decisions. You are an active participant in your own care. The moment you walk into that surgeon's office, you have the right to ask every hard question, to request every alternative, to take every day you need to think. The surgeon holds the scalpel, but you hold the choice. And that choice, made with full information and clear eyes, is the most powerful tool in medicine, more powerful than any operation ever performed. So here's what I'm asking you to do. If this video helped you, or someone you love, think more clearly about a surgical decision, share it. That one share might be the single most important thing you do today. And in the comments below, I want you to tell me one thing. What question would you most want to ask your surgeon before a major operation? Type it out. I read every single comment on these videos. Your answer might be the very thing that helps another senior viewer ask the right question and save their own life. Take care of yourselves. Stay curious. Keep advocating for your own health. You deserve a surgeon who explains everything and a medical team that treats you as a partner, not a patient number. And one final note. Everything I've shared today is general medical education based on published research and clinical experience. Every person's situation is unique. Before making any decision about surgery or treatment, please have a full, honest, unhurried conversation with your own doctor. They know your history. They know your body. And that conversation, informed, direct, and unrushed, is exactly where good medicine begins. This has been and I will see you in the next one.